Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Welcome, Mr. Thomas. How are you feeling today?
Well, about the same as last time.
Let's just take a few moments to review your symptoms before getting to the investigation results.
Yes, so I mentioned last time I thought I had gained some weight, and it appears to keep going. I mean, now my face has become very round, and I have this, what I think is a fatty deposit between my shoulders. It's not a good time for my body image.
And what about the stretch marks that you started noticing a bit before our last appointment?
Yes, that is still there, and now it has spread up my abdomen and down my thighs. I've also noticed that a cut I got working outside is taking forever to heal. I'm not sure if that is related to all of this, but it is quite alarming.
And in general, what is your energy level and your mood like?
Some days I am not sure if it is severe fatigue or depression or a bit of both, but there is a real struggle to get out of bed these days. Also, I'm somewhat afraid to be around my grandchildren because I just feel so irritable all of the time. I mean, the other day I lost my temper over the simplest thing.
I see. So it seems like your physical symptoms are definitely getting worse, and these are affecting your mood somewhat.
I think that is definitely true. So what about those investigations, Doc?
Well, as you probably recall, we carried out quite a few diagnostic investigations. There were the urine and blood tests. With the urine test, we were particularly interested in the cortisol levels. We also had you help us conduct a saliva test to check for cortisol levels as well.
Yes, that was a bit intense, collecting urine over a 24-hour period and then having to remember to get a sample of saliva in the evening.
Yes, so the 24-hour urinary cortisol investigation showed cortisol excretion of more than 3 times the upper limit of normal, which is strongly suggestive of Cushing's syndrome, the late-night salivary cortisol measurement confirming this finding.
Okay, so I understand the high levels of cortisol, and now you're saying they cause Cushing's syndrome? What does cortisol do exactly?
Well, cortisol plays a variety of roles in your body. For example, it helps to regulate blood pressure, reduces inflammation, and keeps your heart and blood vessels functioning normally. It also helps your body respond to stress.
Sounds like serious stuff.
It is. The condition is associated with significant morbidity and mortality, so rapid diagnosis and management are essential.
What exactly would happen without treatment?
Well, there would be bone loss, which could result in unusual bone fractures, and also high blood pressure and type 2 diabetes. Other possibilities include frequent and unusual infections and a loss of muscle mass and strength.
I see. So what causes something like this, Cushing's syndrome?
Well, there are a few different causes, but the most common cause is the use of corticosteroids like hydrocortisone or prednisone over an extended period of time. However, we can rule out corticosteroids in your case because you are not on this type of medication. That leaves your body's own overproduction of cortisol. This is also known as endogenous Cushing's syndrome. Here there are still a few possibilities, including a pituitary gland tumour, an ACTH secreting tumour, or a primary adrenal gland disease.
And so how do you find out which one is causing my problem?
Well, there are a few more investigations to be done. First of all, one to detect plasma ACTH. It is also necessary to get an MRI of the pituitary and a CT of the chest and abdomen. These will help us to identify the presence of a tumour.
So now that you have me all scared, what are the treatment options?
Well, that will depend on the cause, but there are medications that can be used to temporarily reduce your glucocorticoid levels, which would help prepare you for definitive therapy. Surgical management is a likely option, particularly if the cause of your Cushing's syndrome is an adrenal or pituitary tumour.
That is the end of Part A. Now look at Part B.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mrs. Johnson, it looks like you're starting to feel a bit better from when the paramedics brought you in.
Oh yes, definitely. It was awful at first, but now I'm feeling much more oriented in time and place than I did then.
So tell me a bit about what has brought you here today.
Well, I don't remember much about the actual incident, but from what I understand, a colleague of mine saw me holding my head and then losing consciousness, causing me to hit the front of my head against my desk. The paramedics told me that my colleague said that my whole body began jerking and he was unable to rouse me. It sure gave him quite a shock, I can tell you that. Then I guess the jerking stopped and I began making incomprehensible sounds and not opening my eyes.
Yes, I can see the bruising on your forehead and a small laceration on your left cheek. That must have happened during the episode. Did you experience any symptoms in the hours or minutes before the episode?
Yes, I do remember. I had a terrible headache, worse than anything I've ever experienced. It came on very suddenly and it felt like the headache was everywhere and not in just one spot on my head.
And what about any sensory disturbance or weakness before or after the event?
I don't recall any weakness or numbness. However, I did notice that I'd lost control of my bladder afterwards.
Episodes of incontinence are normal in these circumstances. Okay, and have you experienced a loss of consciousness or seizures in the past?
I've never had seizures or anything like this in the past, including episodes of losing consciousness.
And no recent head trauma?
Absolutely not. I mean, I woke up this morning feeling fine. I even biked to work, as I often do.
And Mrs. Johnson, I know you are feeling a bit better now, but is the headache still present?
I still have a mild generalized headache and some nausea. I've vomited twice, but the nurses have just given me some anti-sickness medication, so hopefully that's stopped now.
What about visual disturbances like decreased acuity or tunnel vision?
I haven't noticed any visual problems, but my neck is killing me though. It's quite stiff. I'm not sure if it's because I've been lying in an awkward position or what.
Well, let's see. Try to touch your chin to your chest.
Ouch, that's quite painful. Can't quite get there.
And I know you said you hadn't suffered any head trauma recently and that this is the first time you have had something like this. But I want to go a bit into your medical history to see if it can help us out.
Well, I can tell you that I don't have any medical problems and I'm not currently on any medications. I do smoke 10 cigarettes a day, a 20-year habit, but I try to make up for that by not drinking any alcohol.
So I'm not sure if the nurses mentioned this, but the next step here is to send you up for a CT scan because of the loss of consciousness and headache.
So, any idea of what?
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio.
Now look at question 25. You hear part of a conversation between a doctor and a patient about the results of an investigation. Now read the question.
Hello, Mr. Fields. The results of your cerebrospinal fluid investigation are back.
Great, or maybe, I guess. I mean, my headache is still quite severe and, oh my, the light. Did you possibly close the curtain?
Yes, of course. So combined with your corazal symptoms, the CSF results show that you have viral meningitis.
Viral meningitis? Can you be more specific? What kind of virus are we talking about?
Well, most cases are caused by enteroviruses like Coxsackie virus, but there are other possibilities like herpes simplex virus, mumps, and West Nile.
Well, which one do I have?
Well, this investigation doesn't tell us that. We'll have to do another investigation to determine the exact virus. That will help us to know exactly how to treat you.
Oh, here we go again. I mean, why couldn't you?
Question 26. You hear part of a conversation between 2 doctors about an MRI scan. Now read the question.
Hey, Dr. Bart, can you help me out for a minute? I have this scan, and I think I'm seeing something quite rare, but I want to make sure.
Of course. So let me take a look.
So do you see this right here? The downward displacement of the cerebellar tonsils? Do you think it's a Chiari malformation? But I mean, it can't be type 2, can it? It has to be.
A type 1 Chiari malformation? Yes, I'm afraid so. I mean, here you can see that the cerebellar tonsils are displaced by more than 5 millimeters through the foramen magnum. How old is this patient?
17 was referred to me after he started experiencing headaches and balance problems.
Well, those are common symptoms for type 1. I mean, type 2, he would have been diagnosed much earlier. I would suggest.
Question 27. You hear part of a training on suture materials. Now read the question.
Oftentimes, when a junior surgical trainee is asked what suture he would like for skin, a common response is what the boss likes to use. The answer has a number of purposes: to maintain the status quo and to cover up the fact that many of us have only a very basic understanding of suture materials. So that's exactly what today's session is about: why different suture materials are used and why it matters. So suture types are broadly split into the following categories: absorbable versus non-absorbable, braided versus non-braided, and natural versus synthetic. So for the first category, absorbable sutures are broken down by the body over time by processes like hydrolysis and enzymatic degradation. The amount of time this requires depends on the material, as well as the location of insertion and the individual patient characteristics. For example, the absorption rate of suture can increase in patients with ongoing infection, fever, or protein deficiency. So skin closures of a clean wound are mostly commonly achieved with this type of suture, as it provides soft tissue approximation to aid the healing process without permanent implantation of a foreign tissue. However, not all absorbable sutures are created equally. So the most commonly used
Question 28. You hear part of a conversation between a trainee nurse and a senior nurse. Now read the question.
So how are things going in your first week?
All right, I guess. I mean, the patient in bed 8 just yelled at me. I mean, what can I do? It was necessary for me to do an intramuscular injection.
I know that patient. Did you check if he had a preferred injection site?
No, I didn't think to do that.
Well, he is receiving regular IM injections, so it's a good idea to rotate injection sites.
Yes, his deltoid was a bit bruised.
The next time, maybe use the ventrogluteal. As far as I know, the patient should not have any problem getting into a position that would allow you to use the site.
That's great advice. I will definitely use it next time.
Question 29. You hear two doctors talking about breaking bad news to a patient. Now read the question.
Oh, what a day. I mean, I knew getting into oncology would mean I would be doing a lot of breaking bad news, but it never gets easier.
Yes, it's no easier with my patients, particularly with the miscarriages.
Oh, yes. I can imagine that'll be very difficult. I mean, no matter what I do, it always feels like I'm getting it wrong. I mean, from the moment you start to guide the patient or family to a more private area, they know.
Yes, and there is often so much we don't know about the patient's current emotional state. We can ask them questions to make sure they are following everything, but there's so much more going on in their lives in general that we are not privy to.
And then there is the issue of patients wanting to know all of the information up front about treatment and management of their condition, but there's often a lot we still don't know.
Yes, we often know what the diagnosis is, not the cause or other important factors that will determine the next.
Question 30. You hear part of a ward safety briefing about preventing falls. Now read the question.
Hello everyone. I want to start off today's briefing by reviewing some basic safety recommendations that we should be enforcing with our patients. As a few of you have witnessed and many of you have heard about, we have had several patients had nasty falls in the last couple of days. Now, as most of our patients are post-op, it is recommended for them to get up and start moving around as soon as possible, but a few prevention measures need to be taken to ensure patient safety. The first is patients should wear the red hospital socks or snug-fitting shoes or slippers with rubber soles. They should also use their usual walking aids. We should also be encouraging patients to tell us if they need any assistance. We also had a couple of patients try to take walks up and down the hallway unassisted, and it is not a good idea since if a patient starts to experience difficulties, they may not be able to get our attention quickly enough. So next,
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
Hello everyone and welcome to today's program. I'm very happy that we have Dr. Christina Salem with us to shed some light on a very important topic, diabetes and COVID-19. Welcome, Dr. Salem.
It's an honour to be here, especially to talk about such an essential and timely topic. I mean, there has been so much on the news about this topic, and it's often hard to get the answers that are important to patients.
Definitely, filtering through all of the information can be overwhelming. Okay, so let's jump right in. We asked our viewers to send in their most pressing questions about the topic, and so I want to start with the one that is on everybody's mind. Are people with diabetes more likely to get COVID-19?
At this point, there is not enough data to show whether people with diabetes are more likely to get COVID-19. In general, there is so much we do not know, but the problem seems to be for patients with diabetes is worse outcomes, not a greater chance of contracting the virus. For example, in China, where many cases have occurred, people with diabetes had much higher rates of serious complications and death than people without diabetes. Overall, we believe that the more comorbidities someone has, for example, diabetes and heart disease, the higher their chance of getting serious complications with COVID-19.
Interesting point about comorbidities in general. Why exactly are people with diabetes more likely to experience serious complications?
Well, in general, diabetic people are more likely to experience severe symptoms and complications when infected with any virus. In addition, when people do not manage their diabetes well and experience fluctuating blood sugars, they are at risk for a number of diabetes-related complications. And having these complications in addition to diabetes could worsen their chances of getting seriously ill from COVID-19 because their body's ability to fight off infection is compromised. Another point is that viral infection can increase inflammation or internal swelling in people with diabetes. This is also caused by above target blood sugars, and both could contribute to more severe complications.
What about diabetic ketoacidosis? Do patients with diabetes need to be concerned about DKA?
When sick with a viral infection, people with diabetes do face an increased risk of DKA, commonly experienced by people with type 1 diabetes. Also, DKA can make it challenging to manage fluid intake and electrolyte levels, which is super important in managing sepsis. I say this because sepsis and septic shock are some of the more serious complications that some people with COVID-19 have experienced.
Speaking of type 1 diabetes, are the risks different for people with type 1 and type 2 diabetes?
We don't know of any reason to think COVID-19 will pose a difference in risk between type 1 and type 2 diabetes. More important is that people with either type of diabetes vary in their age, complications, and how well they have been managing their diabetes. This last point of management is key because, like I previously mentioned, what we do know is that people who already have diabetes-related health problems are likely to have worse outcomes if they contract COVID-19 than people with diabetes who are otherwise healthy, whichever type of diabetes they have.
So if a person with diabetes suspects they have COVID-19, what do you recommend that they do?
Well, the first thing is to know the potential symptoms, which include fever, dry cough, and shortness of breath. If you feel like you are developing symptoms, call your doctor. When you make that call, you should have a couple of things on hand: your glucose and ketone readings available, a report of your fluid consumptions, a clear idea and description of your symptoms, as well as specific questions on how to manage your diabetes.
One concern that many diabetics have, especially in light of recent issues with the availability of insulin and other diabetic supplies, is if or how COVID-19 will impact access to these supplies.
At this point, leading manufacturers are reporting that COVID-19 is not having an impact on their current manufacturing and distribution capabilities for insulin and other supplies at this time. Organizations like the American Diabetes Association are continuing to monitor the situation and will provide updates should anything change. The most important thing at this moment, when so many people are out of work and struggling, is to know that there is also assistance for anyone struggling to pay for insulin. All you need to do is contact
Now look at Extract 2. Questions 37 to 42.
So before we get started, I just wanted to introduce myself and talk a bit about the importance of having mental health training as part of your medical education. So I am Dr. Samuel Adams, and I am a psychiatrist who is often involved in admitting patients to the hospital for emergency mental health intervention. Over the last few years, there has been a marked increase in patients coming into A&Es with an acute need for mental health treatment. However, many A&E doctors are not trained to carry out suicidal risk assessment, meaning that many of these patients fall through the cracks. So now let's talk about the suicidal risk assessment itself. As with any patient interaction, it's key to try to establish rapport with the patient early on in the interaction, as this will allow you to perform an accurate assessment of their mental health. This should include introducing yourself and explaining why you are seeing the patient. The patient may also appreciate at this stage an acknowledgement that what you want to talk about with them can sometimes be difficult and that it is confidential. Finally, it is helpful to keep in mind the main objectives of a suicide risk assessment, which are to establish the patient's intent, assess the seriousness and perceived seriousness of their attempt, and assess how they feel about the attempt at the time of their assessment. So, in order to try and establish intent, it can be useful to start off with the day in question and obtain a narrative or an autobiographical timeline of what happened. It is best to start this with open questions and then later use closed questions for clarification. So now we are going to go into different questions and themes that need to be covered in all scenarios to assess suicidal risk. So the first scenario we are going to focus on is self-harm. So it's best to think about episodes of self-harm in terms of before, during, and after. While asking a patient about what happened before an episode, we can focus on the existence of any precipitant. such as an argument with a parent or a recent bereavement. Another main area to focus on is whether the episode was planned or impulsive. Actions that may help you to determine that are whether or not the patient carried out any final acts, such as writing a suicide note or terminating contracts for electricity, or whether or not the patient took any precautions against discovery, like closing curtains, locking doors, waiting until they knew everyone would be out of the house, or going somewhere very remote. When it comes to during an episode, you should ask about the method of self-harm that was involved, what was going through their mind at that time, or whether or not they thought their self-harm would kill them. Common types of self-harm include overdose, cutting, burning, and attempted hanging. You will want to adapt your questions at this point in the assessment to ask specifically about the method of self-harm used. For example, for an overdose, you will want to focus on how they got hold of the medication, as well as what they thought taking the amount of medication would do. As far as after the episode, you can focus on how the patient reached out for help and how they felt when help arrived. Also, in A&E setting, you can talk about how the patient feels about the attempt now and what their current mood is. You might go through different scenarios with the patient, such as if they were to go home today, what would they do, or what might prevent them from doing this again in the future? Once you have covered current and previous episodes of self-harm, you should go into their past medical, drugs, such as negative reactions they have had to or ones they could overdose on, as well as family and social history, the last of which is very important for checking epidemiological risk factors. An important aspect here to keep in mind: if you do elicit risks, then it is important to do something about it, such as if there is a child safeguarding concern. This needs to be shared with a senior nurse or consultant so it can be addressed. Areas to be covered in a social history include living situation, occupation, alcohol consumption, and the use of recreational drug use. At this point, you as the physician will need to make a decision. In most cases, you will have a conversation to agree on a management plan. For patients who are not suicidal and who you intend to send home, you should realize you may be sending them home with no follow-up or support from mental health services. In this case, a safety plan should include reaching out for support from family and friends, recognizing stressors, avoiding harmful alcohol use when stressed, and suggesting they see a GP and contact local mental health services that see people who self-refer. For those patients that do require support of the mental health team, you
That is the end of Part C. You now have 2 minutes to check your answers.